This is Doctor Talks, real talk from real doctors on the issues that matter to you most.
Hello, everyone. Welcome once again to the Prostate Cancer Summit. I'm your host, Dr. Geo Espinosa, and it is my great pleasure to introduce to you Dr. Butala. Dr. Butala is a scientific co-founder of Catch Bio, a company dedicated to empowering individuals to quantify their cancer risk and take control. Dr. Butala is also a physician scientist at the University of Colorado, where his research focuses on using advanced analytic methods on large healthcare datasets, and is a practicing cardiologist. He has received numerous national awards for his innovative research, clinical acumen, and teaching ability, and his work has been published in leading medical journals, including the New England Journal of Medicine, the Journal of American Medical Association, or JAMA, and Circulation. Previously, Neel was on faculty at Harvard Medical School and Massachusetts General Hospital, has worked for Boston Consulting Group on healthcare engagements, and served as an executive director of a free clinic. Neel holds a AB magna cum laude in economics with high honors from Harvard College, and an MD cum laude from Yale School of Medicine, and the MBA from Yale School of Management. Neel completed his clinical training in internal medicine, cardiology, interventional cardiology, and structured heart disease at Massachusetts General Hospital. Neel, what a pleasure to have you on, and my goodness, what a resume. It's so impressive. Thank you for being on.
Thanks, Dr. G. It's a pleasure to be here with you today talking.
How do you go from Northeast, Cambridge, Yale, which is New Haven, and then you end up in Colorado? They must have given you a nice, sweet deal there. How did that? Were you looking for a different pace of life, or what happened? That's a pretty interesting move.
That's definitely a big part of it. I think, the Northeast is great. There's phenomenal, medical and research institutions out there, but I think Colorado is a different pace of life and, frankly, a more balanced perspective on things. And I think that's been really eye-opening for me to allow me to prioritize, things that matter and then really work on things that can help people. So it's been good to have that opportunity in Colorado. It's a difference. Different mindset altogether.
Yeah. We were talking before we started recording, and I was like, God, would I be able to handle that? I guess it would just take time, and you adapt, and then you're like, oh, this is so much better. Maybe now you can't move. You have a hard time moving back to the Northeast, perhaps, if you wanted to.
It's all good. I'm from Tennessee originally, so I kind of get different paces of life, and every pace has its unique advantages. So regardless, happy to be here right now.
Enjoy it. All right, Neel. So the big elephant in the room, let's just talk overview cancer. The sooner you catch it, the better it is in almost all cancers, right? Particularly lung cancer, the big ones, pancreatic. And we are, behind in that process. Typically, when you catch most cancers, is a little too late. And I think that, there's some pretty interesting liquid biopsy technology out there as it relates to that. I am in favor of the patient having, some level of control of their own health and kind of, quantifying, and, that's why I'm a wearable person. I have a bunch of them. I just like to know my numbers as it relates to heart rate variability, heart rate, blood pressure, everything, GCMs, everything. We're far behind as it relates to cancer. How can we monitor our cancer risk? So what's the story there as it relates to cancer? And then we'll dive into prostate cancer.
Yeah, it's a great question. I think, there's so many resources been dedicated to treating cancer once it happens, right? But not nearly as much dedicated to catching it, right? Getting it early, screening. And, there's guidelines that professional scientists have put out and physicians follow that, when you reach a certain age, you get a colonoscopy. When you reach a certain age, you get a mammogram. And really that's applies on a population level. I think those are totally optimized to catch, maximize the resources towards catching people when it matters. But I think on an individual level, there is wide variability in cancer risk, right? So 250-year-olds, both recommended for colonoscopy may have vastly different cancer risks, right? Where one of is highly unlikely to have a positive test result. The second one may be very likely to have a positive test result. And if you find something, it's probably going to be cancer. And so I think in generating, population level guidance, we've kind of missed an opportunity to really individualize, cancer screening and really personalize risk assessment. And that's what physicians try to do in clinic. But on a population level, it's just really hard to say, hey, look, you're a 40-year-old who probably has a cancer risk of a 60-year-old. Maybe you should get screened earlier. Or maybe you're a 60-year-old who is pretty low risk given everything else going on. If you have other competing priorities, maybe this is a lower priority for you compared to, improving cardiovascular health, other things like that. So it's really an opportunity, I think a missed opportunity really to individualize, personalizing, cancer screening and risk assessment really.
Neel, I'm going to ask a question that may sound a little silly or even provocative. Is ignorance bliss? In other words, you have these MRIs, full scans, right? And it's like, oh, you may have something here. And sometimes that something is nothing. And now this thing is in your head and provokes anxiety. You get some sort of technology that tells you, you at an increased risk of prostate cancer or colon cancer or lung cancer. Do I want to know that? And if so, why?
So it's a very individual question, right? So some people may say ignorance is bliss and they want to keep doing what they're doing, and that's totally fine. That's a very rational decision for some people. Some people would rather know more. I think you said you're like a quantified self type person. You probably want to be on the side of getting all the tests if that's what makes you happy and gives you fulfillment and reduces your anxiety, right? Some people feel better, less anxiety with ignorance. Some people feel less anxiety with some sort of concrete, knowledge of a test result. That being said, I think you alluded to the possibility of false positives. And I think you have to be mentally prepared that, hey, if my scan or liquid biopsy or whatever other test you get does show positive result, what's the likelihood I actually do have cancer? And that varies by an individual, right? So 250-year-olds, one with a really high pre-test probability, as we call it, the probability of having cancer, given everything else going on, can vary significantly. So let's say 150-year-old, if I get a positive PSA, odds are it may be prostate cancer. Another 50-year-old, you get a positive PSA, odds are it's probably not prostate cancer. And just depending on all your other risk factors, thinking about you as an individual, the impact of a test result can be very different, and even that same test result. So I think people need to just be informed, right? And that's what I'm super interested. Like, if someone goes through a risk assessment, like what we will talk about in a bit, and realizes, hey, they're super high risk for a particular type of cancer. They may be more interested in doing a more invasive screening versus someone who's kind of reassured that, hey, look, I'm probably on the lower end of risk here compared to other people my age and my sex and my gender and sorry, my race. And so maybe I'll be less likely to do the screening. And so I think really empowering people with that knowledge of what their individualized cancer risk is, I think is super important to then inform that decision making, right? Because it's very individual. And I think it's important to realize that, hey, even if you are high risk for something, it's totally rational to not get screened. Or if you're super low risk, it's also totally rational to get a more aggressive screening regimen, as long as you're mentally prepared that, hey, look, odds are even if this is positive, it's not real cancer. And then as long as you're sort of informed and understand that. So I think it's a very individualized discussion, which frankly, it's hard to have, in a primary care doctor visit for 15 minutes. So that's why, that's why it's important to get that message out.
So many elements to that, right? So,
Mm-hmm.
I deal mostly, well, at this point, 100%, my clinical work is with men, and men just function differently. And we know men on average just don't go to doctors to get screened for anything. Some of them think ignorance is bliss until they get diagnosed, and they're like, oh God, what I should have done is, maybe I should have gone more often, maybe, right? But when they got a heart attack, or they get prostate cancer. Man, I should have had my PSA done 10 years ago, and I never did. Those kinds of things. So I think certainly with men, which I will be the primary viewers of this summit, pretty interesting to how they function, how we function. I'm part of that group to some degree. And to motivate them to, ignorance may not be, bliss. And you want to know. And the other thing, Neel, I wonder what you think of this. I mean, you live in Colorado now. I mean, I have to assume you still work hard and you still do what you need to do from a clinical research perspective, but your stress level might have, reduced, and there's some benefits there in terms of your health and quality of life altogether. When we are at when we are at a higher risk of a particular disease or condition, perhaps you say, okay, you know what, maybe I am moving to Colorado. This is too stressful here. Or, I'm going to eat better. Or, you know what, exercise. I've been meaning to exercise. Now I'm going to turn it up. Maybe there's some element there that motivates the person to take more care of themselves.
Yeah, and I think recognizing that, even if you were thinking about cancer screening or not, or, I think I agree with you. In general, in the US population, people are generally not as proactive about screening for most cancers as they could be. There's a huge gap there of just, what's totally evidence-based people may not be getting in terms of what's rational and what makes sense. But beyond that, let's say you do get an abnormal test result, or let's say you are diagnosed with something like prostate cancer, which we can talk about in a bit, where it's a slow growing cancer over time for many people. If you're caught it really early, there's definitely things you could do to take control, right? So even if you are at a high risk of getting prostate cancer before you're even diagnosed or screened, there's things you could do, modifiable lifestyle factors you could do to decrease the risk of developing prostate cancers. And there's very specific biological reasons, I'm sure, and you and your viewers know, as to why prostate cancer specifically is very modifiable by these things. And then beyond that, even if you are diagnosed with, a very, early stage prostate cancer, there's things one can do to reduce the risk of that growing. And so I think, people think of cancer, it sounds really scary, but really there is a lot one could do to take control and really reduce your risk of developing cancer. And then even if it's something like a low grade or early stage, things you could do to then modify the trajectory. And again, catching it early is super important rather than, the false assumption of ignorance is bliss, and then you're too late. And then again, especially younger men, oftentimes when they're diagnosed, it is, metastatic, and that point, the survival is very low. So I think, catching it early and then understanding that, hey, there's things you could do. It's not something totally out of your control, prior to diagnosis, and even if you are diagnosed, there's a lot of modifiable action there.
All right, let's dig in. Prostate cancer. Give us a little overview. What's the prevalence? How does it, general overview on prostate cancer? Who gets affected? How many? Things like that.
So, Dr. G, I'm sure you and your viewers are probably more of an expert on it at this prostate cancer summit than I could speak to, bigger picture. But I do, my understanding and I think the general medical understanding is that, most people, the vast majority of men, if they live long enough, will have some abnormality that looks like prostate cancer. Autopsy studies of 80 and 90-year-olds, 70% of them have, depending on the measure, have some level of prostate cancer. So more men actually die with prostate cancer of another cause than of prostate cancer itself. That's just how human biology ends up being. That being said, there is a substantial chunk of men who die of prostate cancer. And oftentimes these people are younger, right? And these people have substantial years of life, high quality life that are lost. So that's sort of emphasizes the importance of screening. And that's why really in the last couple of decades, we've been screening very aggressively we've been screening with PSAs. The level of aggressiveness is the eye of the beholder. But so there's been more screening and more diagnosis, and we've realized that a lot of these people will die, of something else and not prostate cancer. But there's still an opportunity to reduce the risk of that cancer progressing, or even people who have not been screened, things you could do to modify your risk of developing it. So that's something I think overall, how the trajectory of prostate cancer has happened. In parallel, obviously, people who diagnosed with prostate cancer has been rapid improvements in therapy. Like therapies have evolved significantly to where even if you're diagnosed at later stages, your survival can improve, but it's still not great. Like I think the latest I heard, like 31% of people with metastatic disease have I think a 5-year survival. Although again, don't quote me on that number because that continues to vary.
Good.
But bigger picture, there's a huge chunk of things you could do to take control. And a lot of these things like diet, exercise, that are pretty standard, but also some things that are kind of surprising that we've noticed in our research. And happy to tell you a little more about that too. But again, there's a wide
what I was going to say is, prostate cancer, yeah, you're right. I mean, that's kind of what I do daily. And it's such an interesting disease because, yeah, most people die with it. All you need to do is live long enough and have a prostate and you'll have it. You can reduce the risk, but you'll have it. But that patient who comes in with a very high PSA, hundreds, 200, 1,000, who, now this is a whole different beast. And so then there's about 32,000 men die from prostate cancer. So they're, again, particularly in that higher risk patient, not only of getting it, but of getting the more aggressive type. If we can catch that early, that's a game changer.
Yeah, I totally agree. And that's actually part of the reason I co-founded Catch, which again, we can talk about, but it's generally Catch Bio is a company that allows you to quantify your own individual risk of cancer. And we look at, 19 different cancers for women, 17 different cancers for men, 21 cancers total, and really look at, based on the available literature, what are the key factors that drive cancer risk? And a lot of these are, just like genetic or, non-modifiable. But a large chunk of this cancer risk is modifiable, things you can change. And so based on, a risk assessment, it's like a big survey right now. You can fill it out. It takes like maybe 15 or 20 minutes. You can really get your own personal quantified lifetime risk of every single cancer, every single major cancer, and then your all cancer risk, right? And so you can then be empowered with that information to say, what am I going to do about it, right? You can say, well, here are some things that I can use to do to reduce my cancer risk, right? So maybe I'm a high risk for lung cancer. Well, here's some things I could change. Or maybe high risk for prostate cancer. Maybe I should eat more soy or do certain lifestyle interventions, exercise more. And there's really specific things people can do for any individual cancer to then take action to reduce that risk. So what we do at Catch is we quantify everyone's lifetime risk based on a risk assessment. And then we provide, action items people can do to reduce that risk. In addition, by giving you your risk, we compare you to the average person, right? What's the average person's risk of prostate cancer, the average risk of prostate cancer across population, and where do you stack up? And if you're sort of on the higher end, maybe you should want to get screened at an earlier age. Or maybe if you're on the lower end, you can sort of wait until the guidelines kick in and your doctor kind of bugs you about it. And so it really empowers you with information that then allows you to then figure out, do I want to get screened more proactively? Do I want to do these things to reduce my cancer risk? So Dr. Geo, as you said, those younger patients, and it's really heartbreaking, who end up having really advanced disease, more aggressive forms of cancer. And a lot of these people would score really high in our risk assessment, right? If they were to join, Catch, they fill these things out. They realize, hey, look, I have a positive family history. I have, maybe someone in my family has some genetic mutation. Maybe I'm doing all, these lifestyle things that may not be the healthiest. All together, when you interact all these terms, it ends up actually being a substantially higher than average cancer risk for an average, 35-year-old. In which case, hey, look, maybe I should be a little more aggressive at PSA screening and things like that. So that I think we really want to empower people that information to give them, individualized knowledge about their cancer risk. And I think for prostate cancer in particular, there's a lot of subtleties that I think are important to explore, particularly for young men who are the most likely to really have, worse outcomes with this.
I'm fascinated with Catch Bio. Maybe we can expand on that a little bit. So I take about 20 minutes. I'll put in my information. It's going to ask me a series of questions. How can I be confident that the accuracy of this is correct? Is there an AI technology involved in this? Is there a bunch of research that's kind of plugged in together to give you your outcome? How does it work?
Exactly. And that's actually where my research background kind of kicks in, where, I have a lot of expertise in predictive modeling using various different methodologies. What we did here, though, for Catch Bio, and in particular, our cancer risk model, is we surveyed the literature very broadly. So we looked at the usual sources. We also used an AI algorithm to find additional sort of sources or knowledge and literature, papers that may not otherwise turn up. And then, as best we could, we actually try to model everything together in a large database. We have a database of about 500,000 individuals that are followed for over 20 years that, from a research perspective, we're able to model the simultaneous impact of all these factors, right? So let's say you see a paper that says soy reduces your risk of prostate cancer by 30%. You see a paper that says, oh, increasing red meat, increases my cancer risk by 10%. Well, if the people who eat more soy end up eating less red meat and vice versa. So these effects may be overestimated, or they may be interactions. So we're actually able to use machine learning or AI or whatever technology you want to call it, but fundamentally use advanced techniques to figure out how we can model all these risk factors that have surfaced in the literature over decades together in this data set of people. And then figure out, well, when we think about a holistic person, all these risk factors at the same time, what's the true impact of each of these? Which one's the most important? Which ones are actually, not necessarily in the causal, more sort of correlate or have multicollinearity. So we basically have come up with these models. We've done these separately for every single cancer, and then we sort of combine them together. So it's actually a pretty scientifically advanced approach to it. We do a general lit review and then sort of joint modeling together, and then combine it using sort of some advanced biostatistical techniques, which we don't have to get into here, but essentially no one's been able to do this before. We're actually drafting a paper, hopefully for publication soon, to really, get this out there too, because we want to make sure that the message gets pretty far. But I think we've used a pretty scientifically advanced approach of collating the literature, jointly modeling everything, and then using advanced biostatistics to really quantify an individual's lifetime risk of cancer. So I think, that putting all that together, I think we have a pretty scientifically advanced model, which I think, we've kind of proven out in a large database already. So
from a prostate cancer perspective, so is the individual putting in their PSAs, their family history, their genetic risk, if they have BRCA2 mutation, what are they putting in?
So yes, all of that except for PSA right now, because we actually want to be pre-PSA, right? I think once you get a PSA checked, in some sense, you've already made a mental decision. You've already kind of been in some sort of algorithm. You've met some criteria, some doctor, someone's told you. We almost want to be, and there's risk models out there for people that incorporate PSA. We actually want to be upstream of that and really
Mm.
talk to the average person who wants to see, like, well, do I even get a PSA? That's often the most, anxiety-provoking decision that a male has to make, right? And so we're actually not incorporating a PSA right now. That being said, if you input your PSA, that certainly helps better quantify your risk, as you get further, right? There's also risk trends we have in our platform. So PSA can certainly help refine and narrow down your risk. But really right now, it's meant to just inform that first decision for that initial screening test. And if your PSA is super high, like, I think you should probably see a doctor. And I'm not sure you want to be relying on, a platform for us to give you that medical advice, frankly. But I think we want to inform your decision based on what's out there and really educate you on things like, do I get a PSA? Well, if I get a PSA, what's the next step going to look like? And what's the positive predictive value of that? And so you're really informed as you're going into that decision. And I think that actually reaches a much broader swath of the population. As you said, many men don't even see doctors, right? So we hope to reach those people who wouldn't otherwise be thinking about things in this way.
How do people, so is genetic risk part of that information that's asked? So if they have a certain mutation and so forth, and if they don't know what that is, do you get them to order a 23andMe or some other test?
Yeah, so right, if you leave it blank, it just sort of estimates the average risk for that. And so if you put it in there, it can certainly, estimate your risk, but otherwise it's a population average. So we can actually deal with missing information pretty well in our models. That being said, that would be one of our sort of action plan recommendations or screening recommendations. Hey, consider getting genetic screening. And again, we don't currently offer it through our platform, but we certainly partner with 23andMe to then eventually get that information imported or have you record it. But there's other services out there, not just 23andMe,
Yeah.
but certainly that, encourage, genetic screening for sure.
In terms of, so you provide them with a certain risk. Let's just stick with prostate cancer. We know that it's for all cancers. I'm actually very interested from all cancers perspective, not just prostate cancer, right? Because men, they get all kinds of other cancers. But let's just say for prostate cancer perspective, they're at a certain risk. And then you say, well, here's some lifestyle modifications, right, that you can do based on science. I do a lot of review of the literature on everything prostate cancer, including exercise and diet. I find that nutrition science is just very difficult to derive information where you can say, well, now I can do this. Why? Because it's just very difficult. There's a lot of variables involved. These are observational studies for the most part. So, for example, the meat studies that say, well, meats are bad for prostate cancer, it's typically processed meats. And it's when you look at other variables, the typical meat eater has a poor healthy lifestyle altogether.
Exactly.
When you look at meat eaters who eat more vegetables, that's a whole different trajectory in terms of their risk of everything and anything. So how will it kind of figure all that, all that out?
So that's actually why we modeled all. So just like you, we surveyed the literature very broadly, and then we put everything together, right? So we're able to, in a data set of 500,000 people, see, well, those who eat, a lot of vegetables and a lot of meat compared to those who eat, not many vegetables and a lot of meat. So we can jointly model the impact of all these things. So what's the impact of red meat consumption controlling for your risk of your vegetable consumption, your fruit consumption, your processed meat consumption, and 20, 30 different variables. So we can jointly model these things together and see, well, given everything else, what is it changing in one variable? How is that associated with the incidence of prostate cancer? And that's why I think it's important. I totally agree with you. Nutritional science is very challenging because it's mostly observational studies, a lot of confounding meaning, one variable associated with another, you don't really see that other one, so you just kind of attribute everything to that one variable. So we actually account for a lot of that through our modeling and a very large extensive data set and our machine learning methods to kind of come up with that. So, I think you hit the nail on the head, and the challenge of doing this, why it's been hard for other people to do this. And so we've been able to do that. And it's been very gratifying to see that.
Well, I have a small involvement with Catch Bio. We had meetings with Neel as well, and the CEO. He's CEO, co-founder, I guess, at this point. And it's lovely to see what's happening with Catch Bio. And again, I'm not an ignorance is bliss type of person. I want to know, and then I want to take some action as necessary and as needed. Final thoughts on screening, Catch Bio, and how do we learn more?
Yeah, I mean, I think, bigger picture, just the idea of knowing your cancer risk is, I think, super important, right? And especially to motivate, lifestyle changes. Because I think, whenever people are relatively young, 20s, 30s, you're like, oh, I'm invincible, nothing bad's going to happen. But really, like 40% of all people are going to get cancer in their lifetimes, right? So we're actually able to quantify your individual risk of cancer over the entire lifetime and show you, hey, if you actually make this change at this age, how much that delta is going to be, right? So if you look at your lifetime risk, let's say I want to eat more vegetables, right? My 1 year risk is going to go from like a 0.1 to like a 0.05, let's say, a very tiny change. But your lifetime risk may actually change, from 30% to 15%, right? If you magnify it over the course of a lifetime. And so really want to emphasize that, joining early, understanding your risk early can allow you to make changes early in your life and really see bigger picture impacts on your cancer risk. And beyond that, this helps you also understand your individualized risk and whether you need to get screened or whether you want to be screened on earlier ages in a more aggressive time interval to really catch things early, because that's where things, I think, make a big difference. So that's, I think, I encourage everyone to at least get informed about that and join Catch. We will, just tactically, I think we're going to launch pretty soon. And I think if you mention Dr. Talks or if you connect with Dr. Talks, we can actually help you bypass the wait list, get you in early, because as an early adopter, I think a lot of people like you, Dr. Geo, or who watch are probably of that mindset. So happy to extend that to you and your followers.
I appreciate it. Dr. Neel Butala from the University of Colorado and one of the co-founders of Catch Bio. Thanks so much, Neel, for coming on and teaching us about this. I think is going to be a very important tool. It's going to be a game changer, I think, in the field, where it's interesting when you said, this is actually pre-PSA. Like, this is to tell you, hey, go get your PSA done. I would have never even thought of that. So I really appreciate that from a prostate cancer perspective and even from an overall cancer perspective. I can't wait. Thanks so much.
Thanks, Dr. Gio.
Thank you, everyone, for tuning in. Again, we're ahead of the game here with the information, with the tools that are available, with the information and the experts that are on for this summit. Thanks again for watching, and stay tuned because there's just a lot more to come. Dr. Gio here, signing off. I'll talk to you next time.
Thank you for tuning in to Dr. Talks. We hope today's episode has enlightened and inspired you on your path to optimal health. Each day is a new opportunity to make choices that empower your well-being. For more insights and strategies, subscribe to our podcast and visit our website, www.drtalks.com. Stay connected, stay healthy, and join us next time on Dr. Talks, real talks from real doctors on the issues that matter to you most.